Hello, everyone. I'm Traci Arieli, end-of-life doula and founder of Comforting Closure. Welcome to another episode. As an end-of-life doula, I have the honor of working alongside hospice teams. I see the care they give, the skill they bring, and the pressure they carry. Hospice nurses, in particular, are asked to do some of the most challenging and important work in healthcare, often with limited time, heavy caseloads, and systems that do not always support what matters most at the bedside. Today's conversation is about that reality. My guest is Peter Abraham. He's a hospice nurse and an end-of-life doula, which gives him a rare view from both sides of the system. Together, we talk honestly about staffing, time pressure, burnout, and the growing role of doulas in hospice care, including where collaboration works and where it becomes complicated. This episode is for families who want to understand hospice more clearly and for professionals who live this work every day and may not hear their experience reflected very often. So grab a warm drink, find a comfortable seat, and join us for the conversation. Peter, welcome, and thank you so much for being here today.
Oh, it's so good to be here, and thank you so much for having me. I really want families to understand not only the benefits of hospice, but also the reality, because sometimes families come in and they have a set of expectations that maybe the liaison, the marketing and sales aspect of hospice brought them into, not realizing the framework for hospice and why end-of-life doulas are often beneficial to have as a part of the journey with hospice. So I'm glad to be here for that,
Thank
to help
you.
with this.
Thank you. Now, I want to start off with you. What first brought you into hospice nursing?
So I'm a second career registered nurse. I went back to nursing school at the age of 50. And while I was going through nursing school, I didn't know what I wanted to specialize in. Nursing is very different than doctors. Doctors will figure out their specialty while they're in school, and nurses figure out their specialty when after they're out in practice. So I did volunteer for a little over a year as a hospice companion volunteer, not knowing that that would provide the framework for later on going into hospice. I just knew that I wanted to specialize, but my time as a companion volunteer, I mainly interacted with the hospice CNA. I rarely interacted with the nurse. I didn't see what the nurses did, but I saw the benefit of hospice. So when I went out into nursing, I first worked in cardiology, medical, surgical. And what ended up happening for me is once I got out of orientation, that's where the hospitals could have you not only go to different floors, but you can get more complex cases. And I started being given hospice general inpatient cases, not as the hospice nurse, but as the hospital side of that equation, the hospital nurse. And I love what I do, but I ask questions. And so I asked, I noticed that when I come in for my shift, I'm always getting the hospice patients. And this is fine. I loved getting them. But why me? What's making you pick me versus another nurse on the floor? And they said, Peter, you tend to be very patient with the families. You take a lot of time answering their questions, and you're very compassionate with them. And I took that as a compliment. And I'm glad for that journey because it helped me become more comfortable with the dying. And even when it comes to morphine, when I had my first experience with morphine was morphine drip. So directly IV into the bloodstream. It's a very high risk. You need two nurses to make one nurse makes the adjustment. The old saying, how many people does it take to change a light bulb? Well, this is one where, yes, I'm changing the knob on the dose, but I have to have another nurse both look, am I doing, how was it set up before? How is it after? Because it is such a high risk medication. And I still remember that case where I was there for evening shift, 16 dose changes, increases each time. And then having my doe in the headlights and my fellow nurses when I'm doing my progress notes at the end, Peter, you look upset. Well, I just reflected, I made 16 increases. And they're like, and this is morphine. And Peter, night shift's probably going to do another 16 and day shift another 16 if he's still with us. And it was like, wow. But as time went on, I had an opportunity to go work for a rural hospice nurse. And so as a rural hospice nurse, so I took that leap of faith. And for me, it was a big leap because I am autistic. I'm introverted in the hospital setting. The pharmacy's there. You can find a doctor somewhere because you have the whole hospital, respiratory therapists. But when you're hospice, it's like whatever's in your trunk of your car, whatever's in your nursing bag, whatever's in the home, those are your resources. And even though, it's an interdisciplinary team, the whole team's not driving with you. We're not like in a van, like in a mobile clinic. We're going there. But once I got into that field, even though I did take a break to work long-term care, I did come back to it. It's a love of mine, a passion for
Mm.
mine.
Now, I'm curious, what does actual hospice nursing, what does an actual hospice nursing caseload look like today?
So it will vary tremendously. This is a wonderful question because just yesterday in one of the registered nursing groups, somebody said, I'm going to get to your question, but somebody said, I'm getting burned out for bedside nursing. I'm thinking about becoming a hospice nurse. And I shared, like, it's a love. It's still a love of mine today. But you have to watch what agency that you go for because a lot of people that become hospice nurses are doing it because it's a calling. Like for me, it's a call. Like when I finally got in, this is my calling. I'm helping people in the darkest hours. I'm helping people where everybody else said there's no cure. And I've had people say I've lost hope. And so I provide a pathway for that as part of hospice. So a lot of the agencies out there, we have people that are bleeding hearts and they end up taking advantage of the bleeding heart. So caseloads, I've had caseloads. I still remember my one, I worked for several hospice agencies in PA and now work in Kentucky, but not as a hospice nurse. But I had one agency, I had a caseload of 29.
Wow.
And what would happen is every 2 weeks, Medicare requires an interdisciplinary meeting every 14 days. And so we get together, and the medical director was saying, let's everybody go over their caseload. Who did I see in the last 2 weeks? And I'm saying, and he's like, Peter, they're on your caseload. Why aren't you seeing them? Me seeing them at least every 2 weeks. I can't. There's only so many hours, like we're rural. So we're driving from the patient to patient. Some might be 15 minutes apart, but a lot were a half hour apart. I had some patients that were an hour from patient to patient. So if you figure of like, not that you have 8 patients with 8 hours apart, but if you have like 8 patients to see in a day, and I've had days where I saw 8 patients and they're all home patients, you have that drive time in between. And if you missed it, like I got to where I document in the home, but here we had other like nurses, part timers, and so on that would fill in the gaps for see the people I couldn't see. And then the pressure is on the plus side where everybody's different. That's a beautiful thing because I look at everybody as being like beautifully broken at stained glass. But the caveat is you have people like me who like to document thoroughly because to me that not only helps me, it helps the patient, but it helps the interdisciplinary team because now they have a complete picture of what the patient looks like. But I've had other nurses that they document like a sentence or two. And like I can't make heads or tails of what's going, like what did they really do for the patient?
So I'm curious, how long is each one of your visits? Usually I see a hospice nurse there 45 minutes, an hour. How long are your visits
It,
usually?
so it's going to vary by the nurse, but hopefully I'm weird in a good way. At least I try to think that. I buck the system. So I would be frequently, and I was never written up because that would create problems for them, but I frequently get chastised. Why am I like this other nurse here is in and out? Like we had one of the agencies I worked for, I had a nurse that would brag that her longest visit only because the wife made her, was 45 minutes, her longest visit. And to put this in the perspective, a lot of the documentation systems will have, like, that's how they pay us. So the computer system will say what your drive time was, how long you were in the home, and how much time was spent documenting if you did the documentation outside the home. And one of my patients was a drug addict, a drug and alcohol. He was alcoholic, he was also a drug addict. And those visits for me would be long when I did them, because I'd come into, he lived in a very beat up environment. I'd come in, there are times I found him completely passed out and I couldn't get him to respond. And his wife, who had MS and other issues going on, and the daughter who lived, like, it was a multi-person household. I didn't know what the relationship with the one family was, but they'd all run the moment I got, shortly after getting there. He's been like this. We can't get him up. Is he dying now? And it happened to be an overdose of sorts. And I'd be there for like 2 hours. That's me. But here, that nurse that bragged the one day that I forget whether I was off or they had me elsewhere, I went in to follow up for to do the next visit. She was the one prior. She was there for 18 minutes
Wow. When,
in the house. 18. And I was mind-boggling, because part of what I had to do is I had to count all the narcotics, both the liquid and the pills. And because we weren't sure whether he was overdosing on the hospice meds versus alcohol versus street products, I would do, this is what he had before. And then when I did my count, I know what he had now, but it also do based on the prescription and based on all the reported pain levels, etc. This is what he should have left.
yeah.
And we were able, because I did it that way, we were able to determine he was actually underutilizing the hospice. He could have been using the hospice meds appropriately. He was underutilizing going street products, but that takes time to do that math and to put it in the computer and so on and so forth. And even just to do the education of, this is what you should be doing to
Yep.
take care of yourself, and this is why this is happening to you. So I don't know how to word. I struggle with wording sometimes, even though, like, I do write books and I write articles, but I'd be one that would buck the system. And there are others that buck the system, but then we end up getting pushed out.
Do you get paid based on the number of people you see
Well,
or how long you spend with them? Like, what is that pay based
so
on?
so it depends on the agency. I like hourly for the particular one in question where I was giving you the time. I got paid hourly. So the plus side is, for those that, and it's not that I want overtime. I am very weird. When I first started at this particular agency, my clinical manager said, "Don't worry, I'll get you miles and I'll get you hours." And I said, "You know what? My car doesn't need the miles, and I don't need. I just want 40 hours or less." I mean, I was already I started in my 50s in nursing,
Right.
so I didn't. It's not that I minded the overtime, but I wasn't seeking it. But I have worked for agencies that are salary, and even with the salary, that form where I mentioned that, find the right agency, there was a person who responded saying they work salary and they're seeing 50 to 60 hours a week salary.
Whoa.
They're not getting paid for those extra hours. For me it wasn't a money thing for to spend the time. For me it was a human thing.
Yeah. So, how do you think that this pressure, this time pressure that you're getting, shapes
It-
what nurses, hospice nurses can and can't offer at bedside?
so what it does for those who don't want to buck the system, I'm not saying that I'm a rebel. But if you have somebody that's like, I want to do what's right no matter what, even if I get punished for it, what they end up doing is they end up cutting corners. They cut corners in what they're documenting, what makes it hard on the entire team. And it also hinders patient outcomes, because maybe they're on a medication that should have been stopped, or something else, maybe a medication needed to be increased. Or they're spending that 30-minute visit, like they're going in and out, in and out. And that's the pressure. To me, one of the main reasons that end of life doulas are rising, that, like, we're having an explosion of end of life doulas throughout the world, and especially in the US, is the hospice nurses and other staff members are being overwhelmed, and either they're not fighting back or they're tired, they're burnt out of fighting back, and they just like, I need a job. And they're afraid of like if they get earmarked, oh, if I get a bad note, like you always buck the system, who's going to hire you? They're afraid of losing their job, so they're going to conform. And then they're not, then the gaps are being created. The family doesn't know. Like I would be surprised sometimes. I'd go in to do a death visit. So the person's already, they've died. I'm there to pronounce. And the family is in shock, not because they died, their loved one died, but they were in shock that the nurse never told them that when they take their last breath, there can be an expulsion of fluids. And sometimes that expulsion of fluids, it might be black, it might be green, it might be very distressing if you're not prepared for. And they were like, our nurse never told, like there, no one told. And I do my best to always uplift my coworkers, uplift the agency that I'm working with. But there are times where it's like I'm speechless, like what do I even how do I even address this? Because in my mind's going, somebody should have said to them this is a possibility. And if they had a well-trained end-of-life doula who is aware of that as a possibility, they could have prepared the family for that.
You know, that's one great example that you just said. It's the lack of education that really affects.
Mhm.
Uh, is there anything else like that you consistently see that's lacking because of this time pressure?
Well, the one case that comes to mind, but it's also going to be a case where this is not me. It's one of my nursing friends here in Kentucky, but she left hospice because of this experience in part, but she was under the same time pressure, and she had a case where the comfort kit wasn't available. The comfort kit, that's where you have the morphine. Typically, it's liquid morphine, lorazepam, either pills or liquid, something for terminal fever if it happens, something for constipation. There may be other medications there. But the comfort kit was not ordered at the time of admission or even days after. It wasn't there. And so she got there, and the person in question was going through terminal restlessness. And while their terminal restlessness, while if you catch it early, you might be able to use non-pharmacological techniques to kind of settle it down. But if it's really bad, you need those meds. So she called in and found a local pharmacy that would have the meds, but they wouldn't have the meds ready for another 45 minutes. And it was soon approaching 5 p.m. That's her end of her shift. She called the triage department to see if one of the nurses at the inpatient unit that's within a 15-minute drive of the pharmacy in question could go pick it up, take the meds to the family, give the meds, see that it worked, stay long enough to make sure that it worked before they left. And when they called in, the way that the triage nurse was going, well, how long is the pharmacy open? And it was almost as if what she got from the feedback, like the how the questions were being asked, that she had a gut feeling that triage nurse would wait until close to pharmacy close to go pick it up, which is several hours, not 45 minutes, and then deliver it. So what this nurse did, she made the decision to do the right thing. She stayed with the family, educated, ran over to the pharmacy, came back, gave the medication, stayed to make sure it was effective, and then left her day. The next thing she's called that day, she's called in the office. She should have clocked out at 5. She should have trusted triage, trusted team, and got written up for it.
Do you
And
do you
that was
think
it.
do you think that this is more of a because you've said that you live out in the country. Do you see this as more of because of where you live, or is this happening in cities also?
I think it's happening in cities. To me, I think we have a nationwide dilemma where there's a great need for hospice, as well as palliative care, which is different than hospice. Hospice is palliative care at end of life, but genuine palliative care is just symptom burden driven. But there's this great need for it. There's not enough staffing. So when you hear about places having nursing shortage, like Pennsylvania has a nursing shortage, Kentucky a nursing shortage, there's probably not a state in the U.S. that does not have a nursing shortage. Well, hospice is a specialty, and a lot of people that go into hospice is a calling. So not everybody has a calling. Some people it is a job. But even then, whether it's a job or a calling, we're impacted by the shortage. So not enough people coming in, but the hospice agencies are more and more for profit. They want to admit everybody that can be admitted. In fact, when on Friday, March 27th, I'm going to be speaking at the South Carolina Hospice and Palliative Care Conference. And my topic is going to be how to get more admissions by changing how we're prognosing, not just checking boxes, but looking at how people die holistically and putting that into practice. But the catch is, if you don't have enough people, then you're compressing everything. And you're going to have people like myself who do buck the system, and like this other nurse who bucked the system and say, we're going to do the right thing even if we get yelled at. But if you get yelled at often enough, like I left the one agency in January of 2024 because like I was begging to go part-time when I was working 50, 60 hours a week. Some weeks were to be 80 hours. Like it gets to be where you
That's
can't take
crazy.
it anymore.
Besides the hours that cause people to burn out, what else do you think really causes the emotional toll that the nurses are going through?
It's when I look at it from a holistic perspective, so that would be the nurses, the social worker, the chaplains, the home health attendants, like the whole team. Is none of us are given. Now, some disciplines might have it more available to them than the nurses and the aides, but we don't get time to grieve.
I was going to
Like
ask
there
you
are some
about that.
patients that, yeah, I've had like some patients I get them, like the average length of stay nationwide for hospices is 18 to 21 days. There's a lot of cases where they're on for 4 days. I've had patients, I admit them one day and the next day they died. But I've also had patients where I was their nurse for close to 2 years. And you get
Wow.
to build a bond with the person, the family, and then they die. And what the expectation of the agencies is you move on.
Yeah.
You don't get to go to their funeral or their celebration of life. Like they
Mm.
will expect you to call and offer your condolences, but that's you get a few minutes to offer your condolences, and then that's about it.
Are there other specific strains that are imposed upon you by the corporate hospice?
There's not uniformity of expectations. And to put that into perspective, when the hospice workers go and deal with our patients, their families, the caregivers, and anyone who was involved on the receiving end, we're expected to be compassionate, to be patient, and to customize what the care plan for them. But when it comes to the managers that are in charge, the executives, they don't always show that to us. It's like I had somebody have a discussion that we should look at trauma informed care to everyone. So everybody's going through something. And I shared with them what I'm going to share here with you and the audience. I still remember the case. This was in the spring of 2022. Uh, I was working for a hospice provider where I had both home and facility patients. I happened to be in a facility, and I was working towards finishing up a visit. And I did have another visit after that, I think, and then it was going to be towards the end of my day. But I got a panicked call from my wife. She said that, she got a concern that her dad wasn't picking up the phone. Her mom my mother-in-law was already in the hospital for a different reason. Her dad wasn't picking up the phone. She drove there and found him incoherent, mumbling in and out of consciousness in the bathroom. Called the ambulance, and she was on her way driving separately, but to get there to Effort Hospital in PA. This is back when I'm working in PA. And from what she was describing that was happening, I knew he was dying. I didn't know if it was going to be that day, it was a Friday, or if it was going to be the next. Just after her call, I got a call from my manager who wanted me to go on yet another visit beyond what I was scheduled. That somebody fell in a bathroom in a completely different direction from where I'd have to go. This was an hour and a half drive to the hospital. And I said, I can't do that PRN visit. My father-in-law might be dying. I'm gonna finish my current visit. I'll do the visit that I was going to do after this the next day because it was not non-critical, but I can't do anything more. And I got screamed at bloody murder.
Mm.
And I said, family first. I hung up. I finished my visit. I had to compose myself, and that's part of the pressure too. I had to, because they don't need all this baggage for the patient. And I made the phone call with the family to give them update for the facility. And then I started my hour and a half drive to the hospital in Effort Hospital. And about partway there, I don't know if it was exactly at the 45-minute mark, the social worker from the agency I was working with called. They got a call from the hospital. The hospital was asking for hospice GIP for my father-in-law.
Mm.
Then it clicked. And this is what was frustrating to me, even now going back. I part of my weirdness is I try to have perfect attendance. So like I don't call off for mental health days, bad hair days, etc. Oh, I just need time off. I only call off if I think I'm contagious type of person.
Yeah.
If I can't get if I'm unsafe to drive, if I might be contagious, that's when I call off. And this was I was already in the second year for this agency. And only after that call, and on that call, the social worker saying that I'm not going to say names, but that my manager apologized.
I'm just going to shift a little bit. So you're a doula also, end of life doula also.
Yes.
And I'm curious, when you first, as a hospice nurse, when did you first hear about the end of life doula role? And tell me about that, your thought. And then I'm going to ask two follow-ups to that.
So I first ran into my first doula in a rural part of PA. For anyone who's from PA, it was near the Wrightsville area. I could say that, but it was in the more mountainy part. Uh, and when I got there, and the family introduced, I don't watch The Pit, but I did see a clips of that episode of The Pit where and this is my end of life doula. So I came into the situation as a rural home. They had their mother, and they're introducing me the husband. It was an adult daughter, her husband, and by the way, this is my death doula. And initially, I am in shock.
Yeah.
And I am so glad. One of the benefits of getting older, and not saying I don't have times when I open my mouth inappropriately, but one of the benefits of getting older is most of the time I can
Yeah.
just shut my mouth and listen. Because when they said that, it's like, what is inside my head? What is a death doula?
Yep.
But I didn't want to come across as being like, I know all questions are good, but there are times where it's like, is this going to be a stupid or silly question?
Yep.
So I did my best to just pay attention and watch. And in the very beginning, when they were describing what she was doing, inside my head, thinking to myself, I'm sharing it out loud with you and your audience, but I didn't say it to them. But inside my head, I do that. I teach this. I would have gone over that because I am that type. Like to me, I love educating.
Yes.
I love teaching. I'd be the nurse I mentioned earlier about the post admit like the death visit where their nurse didn't talk about the fluid out of the lungs. I'd have at the one agent the agency that I first started out with, if the director went out to pronounce, she'd always be checking on all the nurses. Did they tell you this and did they tell you that? And she would come back to me, Peter, every time that I have yours, they say they were well prepared. Couldn't fill in anything after, which I felt good. So it was
Yeah.
great.
So it's
So,
the
but with the
education.
death doula,
Yeah. So you're
yeah,
sitting there with
education.
the doula and you're like, that's my role. That's my job. That's
Yes. and I was thinking, and then and I didn't know, and I didn't inquire on what the relationship, whether it was volunteer versus paid, but I just kept my mouth shut, and I figured, I'm going to be, even though I'm not the proverbial fly on the wall because I'm there and I'm interacting, but it's like I'm going to just listen and watch the interactions. And what happened over, and they were only on service for a few weeks. This was not a month's case, but what I learned is like, wow, they're actually making my job easier because I don't mind repeating myself, but depending on the situation, I have to watch that I'm not getting impatient if I'm repeating myself too often. It's like you probably, I think every adult has somebody that may ask a question just one too many times. And even with the most patient person, you kind of struggle with how do you come across lovingly. And so she was reinforcing the education. She was preparing them. She was dealing with stuff that I didn't think of.
Yeah.
Like as I share what I'm about to share, I never try to promote or proselytize what I believe in. I follow Christ. We don't open windows or doors when somebody's near death. The family was bragging about how she thought to be kind enough to open the window a little bit. And it was like, I'm thinking to myself, not criticizing, I'm thinking like this benefited the family. She knew, she got into the depths of what would make that death and dying experience customized for them. And as a hospice nurse, I didn't know that. And so to me, it was, and then from that time on, I didn't run into doulas a lot, but when I did, it was like, I'm glad that you're here.
Now,
I'm glad that you're here.
I want to
Not
know,
all
since
hospices are
you,
like
since,
that.
yeah, what do hospice teams and what do hospices really think about end of life doulas or death doulas? Because I know they have volunteers, and we've had a huge
Right.
discussion about volunteers versus paid, not you and me, but other doulas,
Right.
about volunteers and versus paid and trained end of life doulas. But I'm
Right.
curious about what hospices really feel about end of life doulas, the paid, not the
It,
volunteers.
it is such a mixed bag. I know my experience here in Madison County, Kentucky, where when I made the decision, and I know we're to come back to what led me to become a
Yes,
death doula.
definitely.
Um, but when I made the decision, I'm going to be both and even though I'll use the term hospice nurse, I'm not officially a hospice nurse because I'm not employed by a hospice agency. It's just that the bulk of my experience is as a hospice nurse. But when I first started calling myself a death doula, I would have we only, how to phrase, Kentucky is one of 24 states that's a certificate of need state. So 26 states have patient choice
Yep.
where there's two, three, sometimes there's too many choices. There could be having choice could be a bad thing. But Kentucky's one of those where there's one hospice agency covering Madison County and all seven immediate surrounding counties. And then there's like, and that's Hospice Care Plus. They're going through a name change. So depending on when this comes out on your channel, it might be Compassionate Care Plus. But then up in Fayette County, there's Bluegrass Care Navigators. But they cover wide swaths of region where you only have one choice. And you don't like your hospice, it's not like you can revoke and find another hospice. You can't. So Hospice Care Plus, when I came out, I'm a death doula. What ended up happening, and it was awkward as all, I'd be doing a community education event or being a part of like a fair. They'd come in, look around, start heading in my direction, but the moment they see that I'm there, they're really beelining in the other direction. And I'm like, are you kidding me? You can't even come up and talk to me face to face.
Why was that? Is it because they are so opposed to end of life doulas or death doulas?
So when I corner them, for lack of better words, and I'm not talking about holding somebody tight, but it's like it's a certificate of need. They have no choice but to use us, and we do everything that you're doing. So it was almost like if you would have went back to when I first met that doula, if I went and cut my mouth shut and I just shut them down, granted that could have caused them to switch hospices. Uh, there, I'm so surprised. In fact, part of the reason why I changed the title I use for me from going for I tried death doula, end of life doula, life transition coach. I'm now could call myself a health and life navigation specialist. Is even when I got to home health agencies, they go death doula. That's so grotesque.
Well, I don't like the
Yeah,
term death doula. I use end of life doula, but I don't
yeah,
even like end of life doula. I
yeah.
do like the
Well,
navigator, end of life navigator,
yes,
or advisor or coach much better,
yes.
because to me it is about, death is one point in time, and the
Mhm.
majority of work I do, is the end of life and trying to make sure that the quality of life is really good.
Yes,
So I
but
don't like the term, but everyone knows it as death doula or end of life doula.
I think the conflict is that hospice looks at us, even though a death doula cannot be a hospice.
Yep.
We can't. And even if you didn't follow the National End of Life Doula Alliance scope or practice, you still couldn't.
Yeah, we're
Like
non-medical.
yeah, I'm a registered nurse, but I'd still need doctor's orders for like the comfort kit.
Yeah.
So I couldn't be unless and with Kentucky being a certificate of need, I couldn't be a hospice nurse. So as a death doula, it's not like I compete with them. And they were actually I went to a health professional networking group earlier this morning, and I shared with them like if there's anything that you're doing that where you want to have an independent party, like I refer people to them. I refer to people to other hospices in Kentucky, but it's almost like pulling teeth to get them to realize that we are a collaborator, we're a partner, we help the journey, we're not competition. And we're certainly not taking their money because insurance doesn't pay us. So it's frustrating and sad at the same time.
How can hospice teams and doulas, how can they start working together better?
So with that, and that's an excellent question. What I'm trying to do is kill them with kindness, kill them with consistency, because what's been happening lately is we're running like myself and the people that they send out to the community, we are running into each other more often, and we're running into each other in more confined spaces where we kind of have to interact. And I'm trying to, and this is hard for me because I am introverted, and I never want to be the center of attention, but I'm making it a point. So, like today's networking group is looking at what's happening in Kentucky. So, I made it a point that, like, for instance, tomorrow, now it'll be past when I'm not sure when this is actually going to be published, but on March 14th, I'm doing a Dementia 101 basics class in the Berea Library. So, I'm mentioning that to them and mentioning, like, this is what I'm out there teaching. And they said, oh, by the way, I know it's not Kentucky, but I'm doing a keynote presentation for the South Carolina Hospice and Palliative Care Conference, where I'm going to be talking to them about advanced prognosis techniques to increase admissions. And I shared as part of that, I said, I know this is geeky nerdy, but I'm out there referring people to Hospice Care Plus, referring people to Bluegrass Care Navigators. And by sharing with them over and over again, I am referring people to you. I'm trying to help you. I'm hoping it'll eventually say again that, wow, we could actually benefit one another.
Yeah, I have met with several hospices in the area just to check them out, because when I work with clients, I'm really fortunate that the clients that I have, I work with them before they're actively dying or in the dying phase. I have people who have cancer, who stage 4 cancer, but they have about 2 years to go. And, granted, we can't really say, but, that's what we're thinking. And I have a relationship with them already. I'm already working with them not only on some grief that they have, of course,
Mhm.
but on getting everything together and talking with their family and doing medical aid in dying and what that looks like because it's legal here in California. But
Yeah.
so I meet with people way beforehand, and I will be making the recommendation based on my clients' needs, what their values on which hospices, which hospice companies are aligned to what they want, their wishes. And but every single end of life doula, death doula, every single one is such a huge advocate of hospice because we understand. Well, first of all, we believe in it,
Mhm.
the use of it, but we understand that the education's not out there. Doctors don't even want to talk about hospice, and we see the value in it. Every single person who, in the United States, we don't do death well. Hospice does
Sure.
death well. And so we do want our clients to take advantage of it because it is such an advantage to use hospice because these are a team of people that are there to help you. All hospices should have relationships with the doulas in their area.
And that's my hope and wish, or sooner than later, because we are sounding the trumpet. And what gets challenging for me is when we're hearing, like when I hear them, when they're presenting what's going on for the community, they're sharing, we want people on earlier because the national average is 18 to 21 days.
It's
And
horrible.
I share, I'm trying to get as many as I can to come in at the 6 month mark because even though there's a stigma to hospice, some people believe that hospice hastens death. There's no studies that show that. On contrary, there are studies that depending on the primary terminal diagnosis, hospice can extend life by as much as 27 months, 2 years and 3 months
Look at Jimmy Carter.
if they start early. And we're the ones sounding the trumpets. We can be that and because we're not paid like they, I don't phrase. I'm okay if they like. It would be nice if hospice paid us, but I'd be okay with saying we're having trouble with this one family. Could we work together? And whether I get paid with for that from that family directly, or whether I do this on a volunteer basis, I'm the type of person I'd rather do that and build headway and show value than have them knock it on hospice because even locally I had one of my friends that's a naturopath was sharing she struggled to get her mom on hospice. She kept on saying she's dying. They kept on refusing that she's not there yet. She's not there yet. When she finally got in, she was on for 4 days.
Well, what gaps do you see that doulas can most consistently fill that hospice cannot because of the constraints that they have?
So there's a couple. And now, as I share this, there might be somebody, watching and commenting, well, the chaplain does this and the social worker does this. And it's not that they're wrong, but everybody's under time constraint. So I mentioned I had my highest caseload was 29. And if you were to scour the internet, you'd find some that has had higher. So I have not had the highest known to mankind, just to be very clear. There's those that have been having in the 30s and even in the 40s, which to me is outrageous. And I do want to mention for your audience, there are industry leaders like Shelley Henry and her husband Adam from the Abney Group. She's promoting that the industry should be 12 to 14 for a caseload, so
I
you
lo-
have time to spend with your.
yeah, I love
So
Shelley.
there
She's
are.
amazing. She's amazing.
Yeah, so I'm glad that you know of her as well. But she's out there promoting this. But here the most chaplains and caseworker, the social workers, they may have the entire census. Like I've worked with the one agency that I worked at where my caseload was 29, the chaplain had like 100 and the social worker had 100. Well, how do you don't get to spend the time? So the end of life doula, for somebody who's well trained, they provide the spiritual support, the social, the emotional, the physical. Within, when I say physical, I'm not talking about necessarily changing bathing. It depends on to what degree they want to align with NIDA's scope of practice limitations or not, because it is an unregulated industry. They could say, I'm comfortable doing a bath, whether because a PCA, uncertified nursing assistant can do a bed bath. They might be comfortable enough to do that. But is the time. A lot of people they discount the time. So even me,
I have
uh,
between 2 and 3 clients that I actively work with at a time, depending on where they're at within
yes,
their journey. I can't do more than that. I
yeah,
can't take care of the client sufficiently and give them the
hmm
time they need without, granted, I'm there a lot longer than the hospice nurses are, but I just can't.
but that's the blessing.
Yep.
That's the blessing because even with me, like when I look back, like, one of my longest visits that was close to 4 hours.
Oh, that's
That's
nothing.
rare. That was rare. They were one breath every almost it was one breath to every 1 minute 58 seconds or so. It was almost every 2 minutes between breaths. And this
Oh.
was talk about another time pressure. They were my last patient of the day. I had an hour drive home. And if they were to pass on my drive home, even within even if I got home and it was 2 minutes before 5 p.m., my manager can call and say I need to head back to go pronounce them because I work till 5.
Mm.
Doesn't matter that I have an hour drive back and I wouldn't get there till 2 minutes to 6 and then have to pronounce them. But I was so afraid that if I left, but even that for 4 hours, that's pushing it. That was a one-time event that in years. Most of my visits that was like an hour and a half. But doulas, for us to be there 3 or 4 hours,
That's nothing.
that's very doable. And so that time is blessing. So there's the time involvement, there's the education, the reinforcing of the education, there's the advocacy of their pain's not properly managed. Or one of the I knew it early on, but again, I'm weird. I'm like I have high empathy. Part of INFJ is high empathy. So to me, spiritual pain, emotional pain, uh, that's all pain. When you talk about pain being the fifth vital sign. But I've ran into other hospice staff that if somebody's in emotional distress, well, that's the chaplain or the social worker's job. And I'm not saying they can't help, but this is where, like, as an end of life doula, we could be advocating and saying we need to address this holistically. And that's part of the picture. And then, like yourself, if you're there, part of what I'm doing too is like advanced care planning long before hospice because I was with a group of lawyers yesterday. I started networking with the Council for Elderly Maltreatment Prevention. And so I was talking with an elder law firm, and they do living wills too. But they were not aware that for that additional instruction area that most living wills have, you could actually put the level of pain sedation you want, how often you want blood sugar sticks for your blood sugar management. Like you can get really fine tune this. But this is what values we bring that most others don't.
Since you're both a nurse
I know
and
that's some circles.
an end of life doula, how has being both of these changed how you understand care?
I think the biggest benefit is to see where the gaps are and then I could try to fill them. It's I guess part of the reason to me, like doing the training session I'm going to be doing tomorrow afternoon at the Berea Library, there's a gap in dementia care for the understanding. So it's just like seeing the different gap areas that exist and then trying to fill them. And part of the challenges of that is there are so many people that are ingrained in the old way. Like you probably know people, us four and no more mentality, or this is the way that we've done it for the last
Yep.
years. That's been part of the challenge. But I think as each and every one of us rise to the occasion, like I love your Comfort and Closure podcast, because every time I watch it, it's like, even if there's points that I have trouble, because we all have different points of view. Like, I'm not sure I agree with this point of view versus not, but I'm getting so much value from it. And so, like, we just push forward and add the value and hope people start coming in.
Now, last question. What do you want families to know about hospice that really can help how they experience it?
The biggest thing to get the best experience, and do you mind if I show you a book for right now?
Please, please go ahead.
Okay.
And for people who
Uh,
are listening, please name the book.
Okay, this is the Hospice Journey Handbook. It is available on Amazon. It was recommended by Dr. Andy Arari. He's a medical director for Vista Healthcare. I don't work for Vista Healthcare, but he said, Peter, families need a book that could actually tell them the good, the bad, and the ugly of hospice, especially in a home setting. So I wrote I had a multi-hour phone call with him. I'm taking notes of what it should cover. I ended up writing the book, send him a copy, and he's like Medicare should be giving this out for free once people get Medicare, so when the time comes from hospice. But the biggest tool, let's say, because I know there's going to be people, I don't need another book, I don't learn that way, blah blah blah. But the biggest thing that I want to pass on to people, if you have a loved one that you're considering hospice, you need to be the advocate. You need to be the advocate. Advocate for hospice and or palliative care early. And if they get involved and when they get involved, don't leave the advocacy to others. Oh, the hospice nurse should do this. Or wouldn't the social worker have told me this? I've had so many cases because I participate in a number of hospice groups. They're asking a good question, and inside my head, I'm like, why didn't you ask that of the hospice nurse, social worker, and so forth? And sometimes I'll get the courage to ask that because I have to first figure out a way. How do I ask that doesn't put them on a defense? But they'll say, I thought that was their job. And technically it is, but this is why the explosion of doulas, because everybody's under the pressure of in and out. Like I had a hospice medical director that he bragged that his physician visits was 15 minutes. And then what ended up happening, and this is because he'd tell me, Peter, go try to get him in the different assisted living facilities to be their medical director. And when I talked to their people, he'd like, he doesn't spend time, like it's 15 minutes. And so if they're in and out, we need to be advocating for a loved one. If you don't think their pain is managed, or you don't think their emotional distress is managed, like here just today, somebody posted in the hospice caregiver support group. They said the hospice nurse is coming tomorrow, but their loved one's restless. What could they give them now? And they were asking social media. Call the hospice and ask for that visit today. Ask them to share what you could do over the phone and send somebody out. And on top of that, keep the visit for tomorrow.
No one's going to advocate for your loved ones better than you will.
Correct.
Well, Peter, thank you so much for being on the show today, for taking the time and for all the work you do and for speaking honestly about the realities of hospice care. Before we wrap up, can you share how people can learn more about you and your work, your books? Where can they find them?
Well, thank you. So compassioncrossing.info, compassioncrossing.info is my website. I'm I love, I'm a geek and nerd, so I have like over 550 articles on various chronic illnesses, terminal illnesses. There's 135 articles on dementia alone, dementia topics. So that's one way. I have my own YouTube channel, the ampersand Nurse Peter, and I'll have discussions on different areas for hospice nurses, holistic nurses, end of life doulas, different topics. And then on LinkedIn, I think it's Peter M. Abraham.
Wonderful. And I'll,
I don't know my social media handles.
That's, social media, whole different topic. But so thank you again. I'll be sure to post those in the description of the episode. Listeners, hospice care depends on people doing complex, demanding work inside real constraints. When we name those constraints out loud, it creates room for more honest collaboration, clearer expectations, and better support for the people doing the work. That's where change starts. It starts with listening and with the systems that better match the reality of care that is needed. Thank you for joining us. If you have any questions, please comment below or reach out to me directly. And if you found this conversation to be helpful, please like, share, comment, and subscribe. This is Traci Arieli from Comforting Closure, wishing you peace and comfort in your journey. Until next time, take care.